Welcome to IBD Insider. My name is Natalie Hayden. I am so thrilled to be here tonight. I was diagnosed with Crohn's disease nearly 20 years ago this summer at age 21, and it was so awesome to have the opportunity to be a part of the 2025 Crohn's and Colitis Congress. We're thrilled you can be here this evening.
And my name is Kayla White, a Crohn's disease patient and ostomate, and I'm so thankful to be with you all tonight. Last month, the Crohn's and Colitis Foundation and the American Gastroenterological Association hosted the annual Crohn's and Colitis Congress, the premier meeting for IBD. Nearly 1,600 IBD health professionals and researchers came together to discuss research about Crohn's disease and ulcerative colitis. Tonight, we'll be taking the information presented at the Congress and bringing it to you during our IBD Insider so that you have the most up-to-date understanding of your disease.
Kayla and I were both patient reporters at Congress, and we were excited to share with you our key takeaways from there. And then you'll hear presentations from some of our expert clinicians about their highlights from Congress, including the latest in diet research, genetics, and symptoms outside the gut. Let's take a look at our agenda for this evening, Kayla.
Here are a few things to keep in mind. The information shared is meant to be for educational purposes only and should not replace any advice or guidance from your healthcare professional. The program will be recorded and posted on the My IBD Learning Virtual Library, and everyone registered for the program will receive a link to the recording next week.
And we want this to be as interactive as possible tonight, so please engage. Send us questions and answers, and we will send us questions. We'll give you guys the answers. There we go. And you can find the question area in the lower part of your screen. You can submit those, and then we will ask our expert clinicians at the end of the presentation and try to get to as many questions as possible. On behalf of the Crohn's and Colitis Foundation and the American Gastroenterological Association, thank you so much for joining. We're going to kick it off with our patient perspectives, and I'm going to share some of the latest revolutionary research when it comes to pregnancy considerations and AI innovations and more. These are some of my disclosures. Starting with pregnancy and IBD, this is where my passion lies. I'm an IBD mom of 3 kids, ages 7, 6, and 3. So when it comes to pregnancy research, this really hits home for me. So let's talk about what was discussed and some of the key quotes that really resonated with me as an IBD mom and for those planning to be a mom in the future. Don't treat women with fear, treat them with science and logic. And we can see that with the latest piano research. And from the Global Consensus Conference just this week, a website launched in 6 different languages, universal guidelines for family planning and pregnancy with IBD. It's remarkable. You got to check it out. Another quote that brought tears to my eyes at Congress was family planning may not be in the thought process of the patient you're looking at in the face right now, but you want to address who she'll be in 10 to 15 years. And as someone who was diagnosed at age 21, I didn't have baby on the brain then, but let me tell you, hearing that quote really hit home because I knew I wanted to be a mom, just not then. And luckily that did work out for me. Now, looking at some of the research out there, remission is recommended at least 3 months prior to conception, ideally 6 months if possible. Prior to becoming pregnant, you want to discuss lifestyle factors early. So that whole body approach and optimizing your vitamins, your B12, your iron, vitamin D, you do not ideally want to be anemic when you go into pregnancy. You want to emphasize the need for continuing medication, the safety and efficacy of doing so during pregnancy and postpartum, while highlighting the safety, of course. Active inflammation for mom leads to worse outcomes for both mom and baby. And IBD pregnancies bring about unique stressors and anxiety. We can't, go through this experience thinking that we're like the average woman. There's a lot of complexity and a lot of extra stressors that go into becoming a mom when you have IBD. So it's important that we recognize that. Moving on to the future of AI and IBD. This is all so exciting. First of all, let's talk about IBD Aware. You can think of this as sweat calprotectin. So instead of giving a stool sample, you can wear a sticker that looks at your sweat and measures inflammation in your body. I thought this was so awesome. It's in clinical trials right now. Basically, it's a biochemical wearable that looks at the sweat and your inflammatory markers. And they have looked at pediatric patients. They've looked at patients in an inpatient and an outpatient setting. And I think it really resonates with the patient community because we are all about having monitor of our disease without having invasive, sorry, my computer's doing something here, without having invasive disease monitoring. Then there's the AI Scribe. This is an ambience tool that listens to your doctor's appointment. And what I think is so great is that sometimes we go into our doctor's appointment and our doctors might be busy typing notes. This allows them to look at you eye to eye, and it records everything from your clinic appointments. And this, of course, comes after you give approval that you are okay with everything being recorded. But this really is a win-win for everybody involved. It generates and orders labs and monitoring tools, all while allowing the doctor to really be there with you in the moment. Then there's IBD Smart Note, which patients just fill out information about their symptoms, their patient journey, their experience, and this goes right directly to research and is distributed to the entire care team. Lastly, there was a lot of talk about obesity and IBD. Get this, obesity rates in our community range from 15 to 40% in the patient population. This does not necessarily rule out the possibility of mineral or vitamin deficiency. So just because somebody is obese, overweight, that does not mean that they're not deficient in those areas. So there's been a lot of talk, a lot of questions in the patient community about GLP-1s and how do those resonate with us? How does it impact our body? How does it impact our prep if we're doing a scope? There was interesting news here, and it actually is all great news for our community. It's effective in weight loss. We respond similarly to the general population when it comes to possible side effects such as nausea, vomiting, and diarrhea. GIs should counsel their patients on what to expect and what dietary modifications are needed because it does slow down our digestion. And modifications may be continued preoperatively, so before surgery or before scope, in patients with elevated risk of delayed gastric emptying and aspiration. Now I'm going to toss it over to Kayla.
Thank you so much, Natalie. Tonight I'm going to be talking about social disparities in pediatric IBD patients, considering new medications, and more. I'm Kayla, a member of the National Council of College Leaders and on the DMV Board of Directors for the Crohn's and Colitis Foundation. No disclosures. So, as someone who was diagnosed at 17, my favorite session focused on pediatric patients from diverse backgrounds and how social determinants of health impact their IBD treatment. Some of the things the presenter talked about was diagnosis delays, interruptions in treatments, more aggressive disease patterns, and higher hospitalizations, to just highlight a few. There was an amazing Q&A session after this session, a Q&A session after the presentation. And some of the things the presenter highlighted was racial similarities don't always equal connection. Patients need both availability and access to their providers, and providers who are racial minorities can also have gaps. So there's gaps in between minorities. And overall, one of the most impactful quotes from this session was a doctor's main goal is to earn a patient's trust. Next, I think almost at least every IBD patient with moderate to severe IBD has had to consider a medication or consider a new medication at some point. So I love that there was a session that focused on this, and of course had a great Q&A session. The Q&As to me sometimes were the best parts because you got to hear the feedback from people in the room. And so some of the things the panel talked about was how they introduce these medications to their patients. So they talked about how will the medication and the data on the medication support your specific case, positioning the medication and being honest about adverse reactions or side effects, and giving the second treatment choice up front. So if we don't have success with this, or if you don't like the way this feels, then we'll try this. Ultimately, giving patients these options and being transparent in the treatment gives power back to the patient and gives them control of their treatment. And lastly, this was one of the more scientific research heavy sessions, really interesting to follow, but it talked about a patient who was on infliximab and transitioned from IV infusions to subcutaneous injections, which I think is something that's talked about a little bit more now with more biosimilars and other methods of getting your medications on the market. So what I thought was really interesting is that the patient that was on the subcutaneous injections at average dosing actually had higher concentrations of the medication in their system when compared to the patient that was on IV infusions. And I think this is important because I know doctors check for medication concentrations when determining if a medication is working or if they need to change something in their IBD treatment. So this was a really, really interesting session. I hope everyone on the call today found our perspectives helpful. At this time, I'd like to introduce our first featured expert, Dr. Oriana Damas. Dr. Damas is an associate professor of medicine in the Division of Digestive Health and Liver Disease at the University of Miami Miller School of Medicine. She also serves as the Director of Translational Studies for the Crohn's and Colitis Center. Dr. Damas will be presenting on IBD-specific diets, how IBD-specific diets can be a primary treatment strategy for patients with mild to moderate Crohn's disease. Thank you.
Thank you, Kayla. That was wonderful, by the way, to hear all the latest updates. You guys did such a great job. Hi, everyone, to everyone that's tuned in. I'm excited to be able to give this talk to you, focusing in large part in diet and IBD, which is a big part of my research. Next slide. And these are my disclosures. And so why are we talking about diet in the treatment of IBD? I think as patients, you all know this is important, but as you can imagine, it's important to mention this to providers because sometimes providers don't always recognize the importance of diet in treating patients with inflammatory bowel disease. And so as part of proof that we know that diet is important is the fact that there have been now several studies looking at the relationship between diet and the development of inflammatory bowel disease. We know this through different types of population-based studies that have now been published across the world. And so what are really the themes of these findings? Well, it's basically that diets that are composed of more Western type of diets. So what does that mean? Diets that are higher in what we call omega-6 fatty acids, higher in saturated fats, lower in fruits and vegetables, but also higher in ultra-processed foods, so foods that you don't even recognize where they're coming from. That's not the same thing as processed foods, but ultra-processed foods like ice cream, for example. And we're starting to see the relationship between these types of foods and the development of IBD for both Crohn's disease and ulcerative colitis. Next slide. And so why do we even talk about diet as treatment? Well, we know that diet is involved in the development of IBD, but can it be used as treatment? Well, one argument to use it is the fact that although we have many different types of now therapies available, which is obviously fantastic, right, at this moment to be able to have all of the different medications with different classes of actions for patients, we still have issues with really being able to treat patients and put them into remission, both clinically and also in terms of their endoscopies, what we call endoscopic remission. And so what this slide here really shows is data from different clinical trials that have led to the approval of these medications. And what we call net clinical remission is really the remission rate after the clinical trial induction period following and then a maintenance period. And the point here is that what you can see in blue is that the net clinical remission, and this data is focusing on Crohn's disease, is that the net clinical remission for many of these drugs still remains low, between 70 and 35%. So that's not to say that medications are not important. That is certainly not the message here. But I want to send the message that medications, there is still a therapeutic ceiling in terms of achieving remission with medications. And you can see on the next slide that we have many different types of therapies, as I've already mentioned to you, really increased over the last 2 decades or so. But again, we really have this therapeutic ceiling, meaning we can't seem to get every single person in remission. And that should really be our goal, right? At the same time, we have and we know that patients require surgery, both across the board for Crohn's disease and for ulcerative colitis. And unfortunately, that percentage of those patients needing surgery still remains unacceptably high. Next slide. And so in the last couple of years, we've really started to recognize that, hey, maybe there's more to inflammatory bowel disease than only focusing on medications, right? So again, medications are extremely important, and it's important to talk to your doctors about getting treated. But at the same time, there's growing data that really suggests that lifestyle factors also play a role. not only as prevention of inflammatory bowel disease, but there's data just that starts to suggest that if, for example, you have a diet that is high in processed foods, that maybe you have a poor response to medications. And so that's important to recognize. And that's really what this slide serves to show here. Next slide. And so this was a face-off that I did in the Crohn's and Colitis Congress. And it was really to try to make the case that although we know what are potential ways in which inflammatory bowel disease is developing, right? We think it's genetics, we think it's the immune system, and we also think there's an environmental component. We really aren't using every single arm of which we know can contribute to the development of IBD. And so we know that, for example, genetics, and Dr. McGovern is going to talk a little bit more about that in the next presentation, but it's led to to a greater understanding of the development of IBD, but we don't have genetic therapies, right? That's a big challenge. We know that that we have focused the majority of or really all of our drugs focused on attenuating the immune response. But the environment is really, including which diet is a really important component. We really haven't focused as much on dietary therapies for IBD, but that is soon to change. And so why use diet as therapy for Crohn's disease? I want to emphasize here that I think before I get into the next couple of slides, is that I do think diet can be used as therapy in patients with mild disease. Now, can it be used as monotherapy? I think that really becomes trickier, and it's really based on disease phenotype. And as it gets to moderate and severe disease, I think the role of diet is more as adjunctive and not as sole therapy. And so why use diet as treatment, for example, for Crohn's disease? Well, we know it's a safe intervention if you do it appropriately, right? We need to be careful about being too restrictive. We know it's more acceptable for individuals, and many patients are interested in hearing about diet. And then we really have dietary treatments for IBD that have the strongest evidence for Crohn's disease. So most of our studies really show some efficacy, particularly for Crohn's. That's not to say it may not help in UC, but most of our dietary treatments are focused, and most of the evidence we have is for Crohn's disease as of now, although we hope to change that in the near future. Next. And so I'll show you in the next couple of slides a few studies really highlighting what is the evidence thus far, particularly in Crohn's disease. Because again, this is a presentation I gave at the Crohn's and Colitis and was focusing on Crohn's disease as treatment therapies. And so we have liquid nutrition, which is exclusive enteral nutrition. This was a study that looked at, well, what's better? Liquid nutrition, called exclusive enteral nutrition, compared to steroids. They did what we call a randomized control trial of 37 kids. And then they compared clinical remission rates, but then they also compared mucosal healing. You may have heard from your doctors about really trying to achieve endoscopic remission. And if your biopsies are also great, then there's mucosal healing. And really what was found from this study was that after 10 weeks of being on liquid nutrition, and it's these boosts, mainly all of your intake of diet comes from nutritional formulas, the greater percentage of patients who were on exclusive enteral nutrition had achieved mucosal healing when compared to those on steroids. So really highlighting the fact and the role that exclusive enteral nutrition can play in the treatment for Crohn's disease. Next slide. And so in terms of mild disease, mild Crohn's, our data is largely focused on using intermittent periods of steroids. And we particularly focused on budesonide because it tends to be focused in the terminal ileum. But what we're starting to see based on the latest data is that, and what I showed you from the prior slide is that really steroids don't do a great job in terms of achieving mucosal healing, really emphasizing the role that maybe we need an alternative treatment, and this is where dietary therapies may really have a role. Next slide. What else can we tell you about dietary therapies? Well, maybe not everybody wants to be on a liquid formula. Maybe there's a way to leverage some of the benefits of a liquid formula, and this is where this diet comes about. It really leverages the benefits of a liquid formula by using 50% of a patient's intake from liquid formulas, from enteral nutrition, and the other 50% from a anti-inflammatory diet that over time starts to increase over phases to a greater percentage of foods and a lower percentage of liquid formulas. But these diets have been studied now in several clinical trials and in several clinical studies that have examined the Crohn's disease exclusion diet. And again, they continue to show a similar benefit to exclusive enteral nutrition. And I'll show you some of that in the next few slides. Let's go to the next one. So this one was a study that was I think it was actually the first study that published on the Crohn's disease exclusion diet, where they compared the Crohn's disease exclusion diet to exclusive enteral nutrition. And what they found was a significant reduction, not just in clinical symptoms, but also in fecal calprotectin. You can see I've highlighted here a 77% reduction for patients who are using part of their diet from liquid formulas. So again, really highlighting that the diet can not only treat symptoms, but they can also improve inflammation. Next slide. And most of the diets in using exclusive enteral nutrition and partial enteral nutrition have been focused in kids. So there's always this argument, is it truly beneficial in adults? Well, there's an increasing number of studies highlighting that actually liquid formula can also work in adults. And similarly, the Crohn's disease exclusion diet can also be beneficial in adults. This is an example of that study. And what you can see here all the way at the right, the bar graph, is that endoscopic remission was achieved in 35% of patients who were on this diet. And what I have in the box in yellow is data from endoscopic remission that was achieved based on a trial that was recently published, a sequence study, and where they achieved 31.8% endoscopic remission with a drug that is now approved, which is risankizumab, really to highlight that dietary therapy can also have a powerful impact on achieving endoscopic remission, similar almost, albeit to some medications, right? There's caveats to really comparing this data to the sequence data and not the same patient population, but it really does serve to show the purpose that we're looking at an endoscopic remission in this trial that was 35%. So that's pretty effective. Let's go to the next slide. And then when it comes to looking at, okay, not every patient can be on monotherapy, meaning only on dietary therapy alone, right? Like I've told you, if you have Crohn's disease, you really need to be monitored and make sure that you, in fact, only have mild disease. But if you have more moderate to severe disease, that's where medications really come about. But can you do something besides medications to improve the chances of response? And actually you can. So studies like this one, this was a combination of many different studies put together. This is what we call meta-analysis. And basically what they found, the authors here, is that when you combine liquid formula in combination with anti-TNFs, right, a very common medication in the treatment of Crohn's and UC, the rate of relapse from Crohn's disease was much lower than when patients were only treated on anti-TNF therapy alone. And I'll add that we're starting to see the similar results in ulcerative colitis. We just had a paper that was accepted and hopefully will be out soon showing something very similar in the setting of ulcerative colitis with dietary as adjunctive therapy. Next slide. And so there's other options, by the way, in case you're not particularly interested in liquid formulas only, or in formulas that are like Ensure and Kate Farm, sometimes they're not palatable to patients. There are studies now looking at, well, how can we leverage the benefits of exclusive enteral nutrition, these formulas, and create smoothies for patients? So this is just one study that looked at a smoothie. This is like what, the foods group that you can see here. And basically patients that were given the smoothies as the main source of nutrition also were able to achieve pretty beneficial results in terms of achieving decreased biochemical inflammation over a period of 4 weeks. So more to come on this later. And this was really to make the case of why is dietary therapy important? Well, because even while we're waiting for medications to be approved, which by the way can take a long time. I'm sure you know that and unfortunately have experienced that. It can take up to 21 days in the United States, sometimes even more, unfortunately. It's really to try to make the case that dietary guidance can be provided in the office, and dietary therapies, so to speak, right, can start the next day. So important to think about that even while you're awaiting your medication. What else? Well, if you're not interested in liquid formula, there's still the potential benefit of food-based therapy. So this was a study that was now published a couple of years ago, and it really compared the specific carbohydrate diet versus a Mediterranean diet. And what was found is that both diets were equally good in terms of achieving symptomatic remission. Although the study wasn't powered to look at inflammation, there seemed to be a downtrend towards a reduction of inflammation on both diets, although they're mainly focused on clinical remission. So what I tell my patients that don't want to do necessarily liquid formula, and again, that's effective for Crohn's disease, is that maybe they can follow a Mediterranean diet, right? So again, avoiding processed foods, avoiding things that are very high in saturated fats, introducing a lot of fruits and vegetables into their diet. Next slide. And then last but not least is really the study that was just discussed in ECHO, which is another conference in Europe, which is a large digestive health conference. And this was a very long-awaited randomized control trial that looked at whether exclusion of emulsifiers, so they're part of these additives in your diet, they're part of what ultra-processed foods are comprised of. And basically, this is the design of the randomized control study. Next slide. But what you can see here is that in patients who were designed or randomized to avoid these emulsifiers, patients ended up doing much better. These were patients in terms of how much they were, the reduction in the low emulsifier diet compared to the control group. So higher here is better because they had a greater reduction. Next slide. And you can see in this slide here, when you look at, well, this is a term called intention to treat, but basically what I'll tell you what these results mean is that there was not only improvement in clinical remission, but there was also improvement in fecal calprotectin, so also in inflammation. Next slide. These were the authors. Next slide. And so when I think about diet for the treatment of inflammatory bowel disease, I like to make the argument that, in the space of inflammatory bowel disease and in treatments, we have this like step up, which is versus top down therapy. And this was a study, the profile study that was recently published, really highlighting that the more aggressive we are from the beginning, the better outcomes for patients in terms of starting medications early. And you can see one arm in blue was really starting medications almost within, I think it was like even 4 weeks of being diagnosed with Crohn's disease versus this accelerated step-up therapy of steroids and then going to an immunomodulator and then going to a biologic, which is no good for really any patient with IBD. And so what I was trying to highlight here is that perhaps there's a space for step-up therapy, for dietary therapies as well, where you have the opportunity to introduce diet either as monotherapy for mild disease or as adjunctive therapy in the process of induction of a medication. Next slide. And so what are some key takeaways? Well, I hope I've made it clear that really I believe, and the data shows, that diet can play an important role in improving disease symptoms and returning quality of life and improving inflammation. Unfortunately, still remains underutilized, but there are several researchers out there and advocates for diet that hope to change that in the near future. The net clinical remission rate for patients with mild to moderate Crohn's disease who start this exclusive enteral nutrition can be comparable to medical therapies, again, focused on mild disease as monotherapy. When it comes to moderate to severe, it's really important to use medications plus the diet and to leverage even diet as exclusive enteral nutrition or using partial enteral nutrition. And you can do 4 to 8 week challenges of diet and see if there's some response. And that should be under the guidance of a dietitian and as well as under the guidance of your GI doctor. Thank you very much.
Thank you so much, Dr. Damas. That was a fantastic presentation. And as a patient, I can speak for the rest of us that lifestyle, diet, it is all top of mind for Crohn's disease patients, ulcerative colitis patients, and all the caregivers out there. So thank you so much. I commend you for that research and work. Now we are very pleased to introduce our next speaker, Dr. Dermot McGovern. Dr. McGovern is the Director of Precision Medicine and a Professor of Medicine at Cedars Sinai Medical Center. He completed his GI training and a PhD at the University of Oxford before he moved to Los Angeles. His groups are funded by the NIH to study genetics and other big data using AI and machine learning to understand the cause of IBD and why there is such a variety in the natural history of both Crohn's disease and ulcerative colitis. Welcome, Dr. McGovern.
Great, thank you, Natalie, for that kind introduction and the invitation to talk. And it's great to follow Oriana. I'm going to talk about something completely different, but people often accuse us of working in silos. So Oriana's working in the diet and I'm working in genetics, but actually we do quite a lot of work together, because where these things come together is where the real power is. So I don't want people to think that we don't talk to each other and don't learn from each other. It's actually quite the opposite. So anyway, it's a great pleasure to share the platform with her. These are my disclosures. So I'm going to talk about the extraintestinal manifestations in IBD. And the reason that this is really important is when I'm thinking about the people I see in my clinic with both ulcerative colitis and Crohn's disease, I think we need to have a holistic view of what their life is like. And of course, a lot of the problems associated with a poor quality of life relate to inflammation in the gut. That's what, inflammatory bowel disease, that's what we're talking about. But 40% of people with ulcerative colitis and Crohn's disease have these manifestations or these symptoms outside the gut. And often those can be worse than the symptoms inside the gut. And importantly, a lot of them can present before the symptoms in the gut. So I think it's very important that we understand what's driving this. I apologize for some of the slightly graphic pictures. Maybe I should have said that in my first slide, so people were warned. But you guys know this stuff better than we do. But people with IBD can have inflammation in the joints, the skin, the eyes, and other areas. And that's what we sort of call the extraintestinal manifestations. But again, going back to this holistic approach, what about other things like cardiovascular disease? If you have long-term inflammation, does that increase your risk of cardiovascular disease? Mental health, there's a huge interest now in the gut-brain axis. We heard about obesity earlier, and that's a big interest of our group. What is this overlap between Crohn's disease particularly and obesity, fatigue, pain, and so on? So there are lots of things that we need to think about when we're just thinking about outside the gut as well. So if we think about what causes IBD, I'm going to talk a little bit about the genetics. We haven't really talked about the microbiome, but of course, the genetics and the diet come together in a way and can influence the microbiome. And then there's a whole bunch of environmental triggers. And when I was training, people used to talk about smoking, and they didn't really talk about anything else as an environmental trigger. We didn't know. But I think, as you heard from Oriana's talk, and you can see on this slide here, we're now interested in a whole bunch of things: pollution, sleep hygiene, diet, stress, as well as smoking, physical activity. All the usual good things that we know that we're not very good in the Western world, and influence our environment around us. Next slide. So this is Joseph Kirschner. Now, Joseph Kirschner was the professor of gastroenterology in Chicago. And I put this up for two reasons. He was the guy who really first pointed to the role of genetics in developing either ulcerative colitis or Crohn's disease. You can see a family here going through different generations. The individuals in orange have Crohn's disease, and that one individual in red has ulcerative colitis. So we know that there's a family history often in people with IBD. So just going back just to Joseph Kirschner, the other thing is about his genes. He was still seeing patients when he was 100 years old. So he had very good genes. as well. So that's another reason that I highlight him. Next slide. So we've made huge progress in identifying genetic parts of the genome, genetic regions that are associated with developing IBD. Now, this is really interesting. We're going to have about 350 of these regions, but we don't know the genes at all of the regions. And it doesn't mean we have 350 diseases. And remember, very importantly, if you carry one of these genetic variants, it doesn't mean you get the disease. In fact, the majority of people who carry the genetic variants never get IBD. It just increases the risk. And then something in the environment comes along on top of that, some of the things that we've talked about. Also should say that the vast majority of the advances here have been made in European populations. And for example, Oriana and I worked together very hard on doing similar studies in the Hispanic population. And we also have studies in the African American population. It's a big, an important part of the work that we do. Next slide. So one of the early things that we discovered with the genetics is that if you have one of these genetic variants that increases your risk of either Crohn's disease or ulcerative colitis, these genetic variants increase your risk of other what people call autoimmune diseases or immune-mediated diseases, things like psoriasis or rheumatoid arthritis. And you can see from the figure here, the size of that pie chart suggests the number of genetic regions that overlap. And that explains just also Joseph Kirschner's observation about the family history of ulcerative colitis and Crohn's disease, but often people have a family history of psoriasis or multiple sclerosis or autoimmune thyroid disease. So these genes run through families, and some people get IBD and other people may get something else, and other people may be totally unaffected. And why that is why we need the research on the environmental side of things, but bringing it together with the genetics. The next slide. So we're not alone in thinking about this. We talk about extraintestinal manifestations because we're gut-centric. We're like Hippocrates here. We think all disease begins in the gut, which points to the importance of diet. But our rheumatology colleagues talk about extra-articular, so out of the joint manifestations. Now, of course, they're wrong and we're right, but the point here is that some people who have IBD first end up going to see a rheumatologist because they get a swollen joint. And it's only after a history is taken or some years down the line that they start to develop the gut symptoms that make them go and see a gastroenterologist. Next slide. So I want to talk about one of the extraintestinal manifestations. It's called ankylosing spondylitis, or spondyloarthropathy, or sacroiliitis. And what it is it's inflammation in the spine and the hips, which is very common actually in people with IBD. So when I'm seeing people in my clinic, and I hope that your healthcare providers are doing the same, they should be asking you about joint symptoms. And one of the big things is, do you get back pain? Now, back pain is very common. And not everyone who has back pain, in fact, the majority of people who have back pain don't have this condition. But if you wake up in the morning and your back is really stiff and it gets better with exercise, then that's something you should be telling your healthcare provider so that we can make sure that you don't have this condition. So the genetics of this is very interesting because there's the most overlap with both Crohn's disease and ulcerative colitis. So this is why we see these conditions together a lot. Next slide. This is another condition called primary sclerosing cholangitis. It's a condition of fibrosis or narrowing of some of the ducts in the liver. And what we see with this is that the genetics of this is more associated with or more similar to ulcerative colitis than it is with Crohn's disease. And this is why we see more of this PSC, primary sclerosing cholangitis, in ulcerative colitis than in Crohn's disease. And what this is beginning, I hope, to give you an idea of is that we're beginning to see, if we look clinically at different patterns of disease. So most people on this call will have a diagnosis of either ulcerative colitis or Crohn's disease, but if they talk to their partners who have ulcerative colitis or Crohn's disease, their disease may be very different. So we're trying to understand those differences using genetics. Next slide. So this is a study that we did recently where we try to bring as big data sets together as we could to try and understand some of the genetics of these extraintestinal manifestations. Next slide. And here you can see the numbers. And so the numbers look really big, but by modern genetic studies, they're not. And this is a problem for us. We really need to get more insights into this. And we're working hard so that people are really being able to report in studies now whether some of the people who are included in that have these extraintestinal manifestations. And that's really important for some of the drug trials that we see. Is there improvement outside the gut as well as inside the gut? Because we want people to feel better generally, not just from one aspect of their disease. Next slide. So what we did is we looked at all of these different manifestations, and I've just listed them here because some of you will recognize some of them. I've talked about the spondyloarthropathy. We also looked at skin conditions, erythema nodosum, which is a painful sort of rash that you sometimes get on your shins, pyoderma gangrenosum, which are these ulcers you can get on the skin, psoriasis, I think most people will know about, the liver conditions, and then another type of arthritis. So if you can just advance the slides. So here you can just see the different ways that we categorize these. And again, advance the slide. And then we brought all of these together because we've heard that people who have one of these manifestations are more likely to have another one of the manifestations as well. And just advance the slide. So this is a really busy slide, and I apologize for that. But I just want to make a couple of points for a minute. The first thing is we identified a genetic association or genetic associations that have previously been associated with some of these conditions, which was really nice for us because it really sort of confirmed that we were going down the right track. But we identified some new things. And so skin manifestations were associated with this one gene, CPEB4. It doesn't matter what the gene is. There's no test for this afterwards on what the gene names are. But the point is that this pointed to new biology that was causing skin-related conditions. And so if we can start to think about targeting therapy towards this, it might be very helpful for those patients. And if you look at the bottom table, sorry, if you go back, if you look at the bottom table, the genes that came out from some of our other studies where we combined these, you can see I've highlighted something called IL-6. And that's because there are drugs already in trial or in use in other autoimmune conditions that are targeting IL-6. So again, if we have people who have some of these manifestations, perhaps this is the right drug from them. And there you see JAK2. And JAK2 is where some of the drugs that we're already using, the drugs called JAK inhibitors, target. So maybe this is another group of people where we should be using these drugs if they're really not responding to other treatments. So if you can advance the slide. I just want to talk a little bit about polygenic risk scores. I know this is getting deep into the weeds of genetics, but I think this is something that people are going to find is going to be used in medicine a lot going forwards. And the idea is that when you've got those 400 regions of the genome that are associated with IBD, each of them has a very small effect, but you can create a score when you bring all of this genetics together. And you can give people a score. Do they have a high score for this or do they have a low score? And people are now starting to use this in screening in cardiovascular disease for hyperlipidemia, even for breast cancer, ovarian cancer, and so on. And we've been doing the same in IBD. And for example, one of the things that we looked at is that we created a polygenic risk score for psoriasis and found that a high score meant people were more likely to get psoriasis than IBD. But some of you will know that psoriasis sometimes occurs after one of the treatments we use, after anti-TNFs. That psoriasis did not have a high score. So it suggests that the mechanisms were completely different for these two types. Advance the slide. And we also looked at venous thrombosis. So some people know that people with IBD have a higher risk of pulmonary embolism or deep venous thrombosis. And we were able to identify a score that predicted people who are 8 times higher at having this risk. And so perhaps we should be treating these people differently, particularly when they come into hospital or go home from hospital, because they're at very high risk of developing these thrombosis. Next slide. And I just want to make this point that the cost of sequencing your genome has dramatically dropped. That's shown in the orange here. And it's now perhaps $250 to do it. And I've just seen, Oriana, how expensive it was to get a comprehensive metabolic panel in Miami there. It's way more than that. And people are getting these all the time. They go to their doctor. But we could get the genome done just for one time. So the idea is that hopefully we can use genetics in the clinic in the future. Can you advance the slide? Sorry, Oriana, I had to put that one in for you. So this is my last slide, really. And this is basically to say, we're trying to think about how we can redefine IBD. Because when you talk to people with IBD, when they're seen in the clinic, there are very many different ways they present or respond to therapy or respond to diet or don't respond to diet, respond to our treatments. And can we think about ways that we can subclassify them so we can get better treatments to these subgroups? And perhaps, Oriana, identify those people who really will respond to the diet. They're the mild people. Is there a way that we can do that? And we're not alone in doing this. You know, the other immune diseases are thinking of doing this. And so you could think of a way that we could identify people perhaps with psoriasis who molecularly look more like some people with Crohn's disease than other people with Crohn's disease. And so treatments would then work in that group of individuals and perhaps not in those other individuals. So I'll stop there so that we have some time for question and answer.
Thank you so much, Dr. McGovern. Absolutely fascinating. I'm the first in my family known to have Crohn's disease, and I've seen many people in the comments saying that they have a family history or they don't. So it really runs the gamut, and that's fascinating research. And now this brings us to our having all our presenters back on screen so we can take some of those amazing questions coming in. If you have a question, instead of putting it in the chat area, put it in the question box so that we can kind of differentiate comments and questions. And then we will try to get to as many questions as possible. We have our first question here, lots about supplements, probiotics, and THC. Dr. Damas, are any of those specifically recommended for flares? And if so, which ones?
So those are all great questions. I was trying to answer some of these questions as I was going along because I see that there's a ton of them. So, right now, I'll tell you that I do think microbiome-based therapies have promise, and that's in the realm of probiotics, or what they're like the big umbrella term, right, for probiotics under that category is how can we manipulate the microbiome? And so they're microbiome-based therapies. I do think there's promise. I will tell you also that I think of dietary therapy as one of the most proven and studied microbiome-based therapies. So diet as microbiome-based therapy. Now, the current probiotics that we have, there's many different available on the market. They're not FDA regulated, which means that we don't quite know what they are really inside. There's supposed to be live bacteria. Some of them are not necessarily live bacteria, right? So there's a lot of variability in what is a probiotic. I'll tell you that the microbiome is very complex, and it gets increasingly complex in patients who have inflammatory bowel disease. So long story short, all that to say that I do think there will be at some point an ability for us to manipulate the microbiome in a more precise way for patients, but we are not there yet. And so the current probiotics have really not panned out to be effective, but there's a ton of limitations. Like I said, there's a lot of variability. So not yet, but don't lose hope. Things that you can do are use natural probiotics like kefir or kefir, yogurt, use fermented foods, right? These things really can replenish your flora in a natural way and in a way that has been studied to be good in terms of increasing diversity.
Thank you so much, Dr. Damas. Dr. McGovern, where should patients go if they're interested in getting genetic testing, and is that covered by insurance?
The quick answer to the covered by insurance is essentially no. Now, there are a couple of exceptions. If someone has developed their IBD within the first 2 years of life, then you can get your genome sequenced clinically. And if that's the case, then I would seek out, there are some specialist centers who are very interested in this. And one place to look is something called the VEOs, that's Very Early Onset IBD Consortium, and look for members of that, because then that's a place where you can get some of your genetics done. In terms of where you, if you don't fall into that, you can go, there are many companies, probably the most famous, and I have no conflict here, as far as I know, 23andMe is the one that most people know about, but there are other companies as well. And what they do is that they will get a saliva sample from you and they'll run your genetics and give you a sort of risk of your IBD, but none of that is actionable. None of that really tells us anything. Where we are doing other genetic testing is in thinking about predicting people's response to medications, and that's pretty common. And I'll just give one highlight because Oriana and I have done this study together just to prove we work together. But there are drugs out there that some people may have been on called mercaptopurine or azathioprine. And there's a blood test that will predict whether people are at high risk of developing life-threatening toxicity from that. Now, what we found was, in a study we did a few years ago, is that people who are from East Asia, so had ancestry of Japanese, Korean, Chinese, were very at risk of this, but they had a different genetic variant than people who are from Europe. And the study that Oriana led and that we were a part of showed basically that the Hispanic population in North America, that genetic variant was particularly relevant in the Hispanic population, the one that we've seen in East Asia. And there's some historical reasons why that may be the case. But in terms of what you're doing in your clinic, it's very important that we think about those things when we're doing genetic testing. The final thing I would say is we're always desperate for more people to help us with these studies. So if you have an opportunity to volunteer for one of these genetic studies, your data is going to, I think, a really good place, really good causes. I gave you one example, but we're discovering a lot about IBD from these genetic studies.
We sure are. We can really pave the way for the future of IBD if we can lend a voice and lend our experience. So I thank you for that, Dr. McGovern. Dr. Damas, what diet advice do you have for patients who suffer with strictures or obstructions? Is fiber recommended?
Yeah, I was seeing that question. It's a great question. I want to answer that briefly and also talk about UC because I see a lot of questions on there. On ulcerative colitis, I'll tell you that the story on fiber is evolving. We used to think that patients who had very active symptoms should avoid all types of fiber, and this is where the low residue diet, or even, so to speak, the low FODMAP comes from. Now, what we're finding is that actually fiber is really good. It's particularly beneficial for the colon. It attracts good bugs. It's good for your intestinal lumen and integrity. So in lieu of that, and there's been studies showing that high fiber diets are actually good and they help keep patients in remission. The second thing, or I should say maybe the third or fourth thing, I've said a couple of things now, is that fiber, we've also found through some more recent studies, fiber can be tolerated if taken in appropriately in patients with active disease. So, but that has to be more insoluble fiber. So has to be more soluble fiber, not insoluble fiber. So those two are different. Insoluble are things that we're not set up to digest as human beings. Those tend to be, for example, like the roughage or like the cover of like cherries, for example. So if you want to tolerate fiber, you want to increase your fiber intake, you should have more soluble fiber. Avoid the insoluble fiber. The same is true for patients with strictures. Now, in terms of ulcerative colitis, really quickly, because I saw some patients who are concerned about not having UC and not thinking that diet plays a role. Diet absolutely plays a role in ulcerative colitis. There's studies showing that the Mediterranean diet can help prevent relapses in UC as well. Unfortunately, it's true. Exclusive enteral nutrition has been proven to be effective in Crohn's, not necessarily in UC. I know there's some studies that are reevaluating that right now. We also have a clinical trial UM that's looking at a Mediterranean type diet. We're using some cultural fruits, some Latin products in ulcerative colitis. And I'll tell you that I also just did a pilot that looked at UC patients and adding diet as adjunctive therapy to their medication, and there was a signal for improved response in UC. So if you have ulcerative colitis, do not lose hope, continue using or adhering to a healthy diet because it is also beneficial.
And I just have a follow-up question that I saw in the comments, and I think this really resonates with people that are on this call. It really spoke to me. A mother whose son was recently diagnosed is off to college. So say your child's away from home, they're living away, they're in the dining halls. What should that student do?
Well, I mean, look, I think it's difficult, right? Because if they were maybe in Italy, it'd be a lot easier because things are more naturally unprocessed, right? But things served, unfortunately, in the United States are going to be more naturally processed than any other country, and that's just the truth. There's studies showing that. I can tell you that teaching your kids and your teenagers, and I guess your college kids at this point, to read the labels is very important because I think education in nutrition is really the key because we have to become savvy in understanding what we're putting in our mouths. That's just the truth. And I think it's important for people in general to know more about this because the more you know, the more you're able to adhere to a healthier diet. It's not just what we're learning about eating fruits and veggies, it's also trying to avoid some of the ultra processing that's in those in foods in general. Trying to cook meals at home if at all possible. And of course, you know, sticking to the fruits, veggies, portion control, avoiding the saturated fats, if at all possible. So the fried foods in that dining hall, and then try to teach the college students to cook at home. Maybe that can be a possibility. I know it's hard.
Thank you so much. And our final
I actually have something to add to that. As a college student at New York University, there was dining hall accommodations that I was able to get that allowed me to pay less for the university mandated plan. And using that money, I was able to buy more foods to cook in my dorm. And also had accommodations to be able to ask the chefs if they could cook food down or prepare it a different way if I couldn't eat it at the dining hall that was close to my dorm.
That's fantastic. Thanks so much
Great.
for And Dr. McGovern, for our final question of this evening, why are people with IBD more susceptible to blood clots? Is that more genetic or lifestyle related?
Yeah, we didn't find an increased risk of the genetic risk of blood clots in IBD. People with IBD are at increased risk of blood clots because they have a very high inflammatory load. They've got a lot of systemic inflammation, which is coming from the gut. They tend to be dehydrated and tend to be, when they're particularly sick, less mobile. And then some of the medications, in theory, can increase the risk. Corticosteroids that we heard about can all do that. So they're at a high risk for all of those reasons. And the study we did was really to see if we could identify people at very high risk because they also had the genetic background layered on top of all of those things.
Very interesting. Well, thank you all so much. This was a great discussion. We learned some really helpful information today.
Thank you.
Thank you. Thanks for having us.
And Kayla, I'll let you close it out.
Of course, our program is coming to an end. This is all the time we have for today. On behalf of the Crohn's and Colitis Foundation and the AGA, we encourage you to keep learning about IBD and to visit some of our helpful educational resources. I want to remind everyone to please fill out the evaluation survey that will be sent to you after tonight's program. We really appreciate the feedback and it will help us plan future programming. Thank you for joining the IBD Insider Patient Education Program and have a great rest of your weekend.